And then we're going to have the Instagram video today. So I'm trying to figure out what I want to do. Let me show you some of the research that I got from the doctor that I work with. So she gave us all like this little informational packet that she put together. Amazing doctor, amazing. Mind you, she came in on her day off to do this with us. So let me find a spot to prop you up here. Okay. I actually accidentally pressed post on that, but all right, so the first part says management of sickle cell patients in ED in compliance with a new ED pain protocol. So there is officially a new ED pain protocol, very, very much tailored to the sickle cell patients, but they go into more about chronic pain patients in general. Let's go down and read some of it to you guys. So if patients are presenting with sickle cell anemia to the ED and have no pain protocol in the problem list, because there's a problem list in their chart that you click on this little link and it opens up this whole pain protocol. If they don't have that and they are members of this hospital, please call Dr. He may follow up on this because this is something that they are taking very seriously. You need to have a pain protocol if you want pain medicine, if you're someone with chronic pain. And just because the pain protocol says something doesn't mean that's necessarily what's going to happen either. So if this is before 10 p.m., please page the sickle cell doctor. We have a sickle cell doctor, okay, on call via operator, so you know how to treat them in the ED. If there is no callback or it is before 10 p.m., call so-and-so directly on his cell. If you are having an acute sickle cell emergency, call sickle cell on-call doctor regardless of the time. These include acute chest syndrome, splenic or hepatic sequestrations, priapism, stroke, and bony infarction with fat emboli. Any patient presenting to the ED for sickle cell pain crisis, whether or not they are admitted to the ED, they need their charts info forwarded to the sickle cell case manager. Again, gives me her name and phone number. This closes the loop on the sickle cell team, knowing about a break in protocol if there was one, and there is less return visits to the ED for us. So basically they're trying to get like a system in place, not just like, oh, I'm having a lot of pain, I'm going to go to the ED and ask for this, they're going to give me this, and I'm going to feel better. Like, yeah, sure, Dilaudid may make you feel better immediately in that moment, but this is a big picture thing. Why are we having so many crises? Like, if this is a 1 in a 10-year thing, they're probably just going to give you the IV Dilaudid push. Yeah, but if you were there 4 days ago, and 4 days before that, and 4 days before that, we got to figure something out. Something's not working for you is the problem. Okay, so, and then in big, bold, giant letters, it says there is no more IV push Dilaudid, Benadryl, narcotics of any type. All pain protocols that are written in the problem list for sickle cell patients will be given. So their protocols are now being changed, is basically what I'm telling you. So they may have had IV Dilaudid in that, like push Dilaudid in that pain protocol. Well, it's changing now. And it's changing because of the ER. We're the ones that are doing this whole closed loop thing. So all pain protocols that are written in the problem list for sickle cell patients will be given as IV drips over 3 to 5 minutes, even if it says IV push. So whatever your pain management doctor, your whoever says, great, love that for them. They can do that in their office. We are not. There's a bigger reason for this. It's not just like we don't want to give you that. No, it's because people keep coming back for more. Your pain is not under control. We need to do something bigger, something else, not just keep slamming you with Dilaudid. That's not the answer. I know you like it, Katie, who doesn't even have sickle cell and has no business getting IV push meds. Like, that's what I'm saying. Like, we're at a point where now even sickle cell patients are having a problem where we have to change the administration practice. So, and this is very interesting because I had a sickle cell patient the other day who was very adamant about wanting IV Benadryl, and the doctor was like, irritated with me and this was before I didn't have this policy yet. There was no official policy. They had been talking about it, but he was like very annoyed, and I was like, well, they always give it, so I don't know like what the problem is now. And he's like, well, you'll see in a couple days. So basically I understand what the whole thing that they were working on. So patients with Dilaudid and Benadryl can be mixed in the same 25 or 50 ml bag, given over 3 to 5 minutes. Patients with their basic sickle cell pain and pain crisis do not always require admission. So basically, if your pain is able to be controlled, we're not going to admit you. And then if the protocol that we are doing in the ED is not working, then you will stay. And, they'll deal with it over the next couple days. The clinics have already made the patients aware that if they come to the ED as of January 1st, 2014, This is not new, okay? They're just reinforcing. There's no more IV push Dilaudid or Benadryl. So they have still been doing it, though, because I noticed when I came here to California, like, there was no Dilaudid. I was like, where's the Dilaudid at? They don't very rarely give it unless the patient is admitted. Very rarely give it in the ER. The place I'm at now is one of the hospitals that was still giving it, and now they're not doing that anymore. So it's like, I just would like to hope that this opens Janina and friends' eyes to see how their behavior is giving them real life consequences. Like, and to me, this isn't a consequence. This is how these medications should be administered, because slamming Dilaudid isn't helping anybody. You guys might feel like, oh, it's getting my pain down really fast. Okay, well, if you've been in pain for 6 hours, you're going to be okay for another 5 minutes. And the repercussions or the effects of slamming that medication is way different than giving it to you in a drip. And as a nurse and a responsible administrator of medications, I'm going to put it in the drip. So, and let me tell you, I love giving patients meds and making them feel better. And, you know, it gets to a point where it's like, well, why were you here 4 times this week? Oh, because you want the same thing. And now they're not getting it. And it's funny because when you stop giving them that, they don't come anymore. So are they really in that much pain? I don't know, because you have to understand that these patients have a pain regimen at home. So that means they've exhausted everything at home. They have oxycodone, they have morphine, they have oral Dilaudid, they have all these things. There's a thing called tolerance too. So, I mean, at that point, we have to like break it down to a very individualized level where it's like, you need to be using those meds only when you absolutely need them. And I'm not saying that you're abusing it. People are abusing meds though, and that's the thing that happens. You can be very sick and require opiates and still abuse your medication. And I feel like that's a thing that's like, we don't talk about that or something. I don't know, but like that's a disease process, and that affects your outcomes, that affects your plan of care, that affects the way people treat you. You have to address these things. You can't just go around having a raging addiction to your breakthrough meds and, you know, wonder why you're having so much breakthrough pain, because you're not using your meds appropriately. So anyway, there's that. They do this every day for 3 days. So it may take the body some time to get down from that crisis, but it really doesn't make a difference. In regards to the medication administration, you're still going to get that medication in your system, but we're not going to give it to you to where you're going to feel a rush. You're not going to feel like, ooh, I feel good because the serotonin is blasting me right now. That's the feeling you're getting. It's not